Everybody's favorite topic of conversation, oral anti-hyperglycemic medications. If you want to learn or refresh your learning on insulin, that's in the video on diabetes type 1, since it's much more common for people with diabetes type 1. You will, however, find a lot of people on these medications, we call them OHAs, who are also on insulin. But the goal is to try to manage as much as possible, as long as possible, with diet and with these lovely drugs that we're going to talk about right now. So first and most importantly are the biguanides. I don't know why they say biguanides, because there is only one biguanide, and it's called Metformin. The generic name is Metformin, and the trade name is glucophage. I never call it glucophage, so I'm actually not sure if I'm saying that right, but Metformin. Mostly everyone just calls it Metformin. So yes, this is your first line treatment. You get a question on an exam, that's your first line for not just for diabetes type 2, but for pre-diabetes or impaired fasting glucose, which again is just another name or another way to describe. So what does it do? It decreases hepatic glucose production. That's the main effect. That's the main thing it does. At the same time, it's going to decrease absorption of glucose in the intestine, and it's going to increase insulin sensitivity. So when you increase insulin sensitivity, you're going to increase glucose uptake in all of those peripheral muscle cells, and then they're able to use them, and that's going to decrease the amount of glucose that's in your blood. It also decreases insulin resistance. What's important, this is really the big thing about metformin that comes up on tests, is that it does not stimulate the secretion of insulin. If you look at all of these things that I just talked about it doing, not a single one of them says anything about actually increasing insulin. They're all about decreasing glucose. And so that means if someone takes it, we're not as worried about them having a hypoglycemic reaction. So what did we say that it does? It decreases hepatic glucose production. So let's look down here at this little kind of drawing of the glucagon insulin feedback system. If you're unfamiliar with this or you want to brush up on it, it's in the first video about diabetes type 1. But we said that metformin, as a biguanide, its main effect is to decrease hepatic glucose production. So if we look here, when our glucose is low, right, the body stimulates a release of glucagon, which then triggers this, the liver to begin breaking down glycogen and creating, it's not written here, but it also causes gluconeogenesis, right? And so that is its main goal, is it stops this from happening. If you stop that from happening, you don't have any extra, glucose floating around in your system. Your body will take the glucose that is there, that's floating around. It's having a problem being used because there aren't enough functioning receptors on the muscle cells. But instead of getting more glucose into the system, which will just cause hyperglycemia, it kind of allows for some time for that glucose to find a receptor that works and to find a way into a cell, instead of just increasing and increasing and increasing the amount of glucose that is in your system. So that's kind of like the main thing that metformin does. There were a couple of other things. I think one of them was decreasing the absorption of glucose in the intestine, meaning that when we eat, that most of our kind of nutrients are absorbed in the small intestine, and then they go into our bloodstream. So if we decrease the amount of glucose that is actually being pulled out, then that glucose doesn't go back into the blood system, it exits the body, and we don't have hyperglycemia. It's just one smaller way of helping. it increases the insulin sensitivity on the peripheral muscles, peripheral cells. So that's up here, right? It's going to have an effect on, again, like I said, instead of creating all this extra glucose to float around in the body, we're actually going to just try to encourage the glucose that we have that's floating around to actually uptake into the cells. And it actually has a way of increasing that sensitivity and the glucose uptake and utilization and decreasing insulin resistance. Again, metformin is kind of like your main guy. It's the one that most of your patients will, many patients will be on your metformin. It has the added benefit of improving your lipid profile, which is kind of nice. One of the big things a lot of these medications do is they tend to cause weight gain. And so what's great about metformin is it actually does the opposite. It causes a little bit of anorexia, and so people tend to eat less and lose some weight. Big thing to remember for metformin, this is like your, I don't know, for each drug, there's like 2 or 3 things that you just, that are your main recognizable, gonna pop up on a test thing. One of those is this metallic taste. That is a normal, transient side effect. It's nothing to worry about. And the other kind of big thing is this iodine or contrast dye. I tried to, as I was making this mind map, I tried to like highlight the main thing. So if you don't have time to go through and read all this, and you certainly should not go through and try to memorize all this, what I would do is I would go through and try to make sure I understand just the basic like mechanism of action, and then know these like big things. Anything that's in color or anything that's bolded and maybe in a different font, those are the important things. So again, iodine or contrast dye, it can have a really negative effect on the kidneys if you mix these two things together. There's already a risk for decreased renal function, I guess, with metformin. And then if iodine, as you know, is heavily excreted through the kidneys. And so we don't want to mix those two things together. So we always take somebody off of metformin a couple of days or a day before they have to use this iodine or contrast dye. And then I believe they're off it for 2 or 3 days after. I'm sure there might be other reasons, but I was always taught that it's to avoid this problems with renal function. So there are some GI effects, nothing to worry about. Again, we want to check renal function and hepatic function. We don't use this in DKA. It's not going to do anything. Actually, before I go on, one of the big things to know about all of these oral anti-hyperglycemic medications is that they only work if you have some endogenous insulin in your system. So none of these will work for someone with diabetes type 1. They only work for diabetes type 2. Back in the day when they originally started making these biguanides, I can't remember the name of one of the original ones, but it's basically settled on metformin. That's the only one now. It used to cause a real risk for lactic acidosis. It was happening a lot, and so whatever they did to fix that, they did. They released metformin, but there's still a very small risk, and so we definitely are not giving metformin in the case of DKA or any other type of acidosis. To be honest, we're not giving oral antidiabetics if somebody's in DKA anyway. And you remember up here how we said it does cause some GI, like nausea, vomiting, diarrhea, heartburn. It's better to take it with meals, and we can kind of decrease those GI side effects a little bit. Okay, so I don't say any of these properly. Sulfonylureas. I've never have to say them out loud. What you will read is glyburide, glipizide, and glycoside. That's what you need to know. Just keep in your mind there's sulfas. These work a little bit differently. Just so you recognize the names again, glyburide, glipizide, glycoside. The brand names are diamicron and glucotrol. What these do is they bind to these specific sulfa receptors on the beta cells themselves, and that stimulates a release of insulin. So when you have a release of insulin in your body, what does it do? If you're not sure why I've written these two things in here, go back to the first video and check out what endogenous insulin does. But it works against glycogenolysis and gluconeogenesis, and that makes sense if you go back and look it over. Again, it's gonna go against glucagon secretion. Why? Those are opposites in a feedback system. So if insulin goes up, glucagon is going down. So it's working in a very different area. And because of that, if you look back down at my little drawing here, which hopefully we will be able to find quickly. Sorry about that. Sorry, let's pull that up. So we said these sulfonylureas, glyburide is the most popular, so I'm just going to say glyburide, is actually causing the pancreas to release more insulin. So if you just think about that, is that going to cause a risk of hypoglycemia, or of your blood sugar, your glucose levels going too far down? Yes, it's going to do that, right? It's going to actually, it's creating more insulin. So we need to keep on guard for hypoglycemia. Again, I'm sure that yes, I did. It's highlighted here for you. So again, having an idea that the main thing it's doing here, even if you just know that, these things will come, these two things will come as common sense if you understand what endogenous insulin does anyway. So you don't need to memorize that. Photosensitivity, the only reason I put that here is because glyburide, glycoside, these medications are actually sulfa drugs. And if you remember back to when you studied infection control, and antibiotics, you'll recognize this. There are sulfa drugs that are antibiotics. Many people have sulfa drug allergies. And you actually cannot give glyburide or glycoside to a patient who has a sulfa drug allergy. This is something that comes up in NCLEX prep questions a lot, and it confuses a lot of people. And so it's really, I just kind of want to encourage you now to just start thinking of these drugs as sulfa drugs. They are sulfa drugs, and so they're going to have similar side effects, for example, photosensitivity, and you're going to have a cross sensitivity. So we need to be careful about that. Hopefully I'll get around to making a video as well on side effects, and should we take this with a meal or without a meal or what have you, of all those antibiotics, because that is extremely important for the NCLEX, and we all know it gets a little bit confusing. Again, we're going to caution hepatic disease, renal impairment. All of these medications, you're going to kind of caution, check out the patient's creatinine. We're not worried if the patient has, like a low grade CKD or whatever. If it's severe, again, that's when we're going to be cautious. And it's not even necessarily a contraindication. It's just, we need to keep an eye because it can increase the risk of hypoglycemia. My glutamides, don't see these as much. I don't think I've ever seen Starlix in practice. Have seen gluconorm. What this does is it closes the potassium channels in the beta cells, and that opens up calcium channels. There's a video I talk about all of that, so if you're confused, you can look at it. But for now, if you want to just memorize it, that's fine. So it opens those potassium channels, or closes the potassium, which opens the calcium, and increases your insulin release. Again, we're increasing insulin release. So you're going to have these things going on. No problem there. Really important to remember, this is rapid and short term. It's not something that necessarily works for the long term, will work all day, whereas metformin, for example, you give it in the morning and you're good to go. It's just very rapidly absorbed and eliminated. And because of that, even though it's doing the same thing as a sulfa, it's causing an actual release of insulin. Because it's so quickly absorbed and eliminated, the risk of hypoglycemia is actually fairly low. Other than that, there's nothing really like crazy important about this. I wouldn't worry too much about any of these other things. Remember that it's rapid. This is logical, but I'm going to go over it anyway. If something is rapid absorbing and rapid acting like that, and it increases insulin, you just have to think that through. If I'm going to give a patient something that is going to shoot their insulin level up fairly quickly, then I need to make sure that there's actually glucose in their system for the insulin to work with. Otherwise, the patient may have a hypoglycemic reaction, even though it's so fast acting. So one of the important things is for these medications, again, gluconorm, replinoglide, is making sure the patient is going to eat within 30 minutes. We don't give it to someone if they're not going to eat. Whereas, for example, if you look at metformin, this is one of the questions that often comes up on exams about metformin. You're giving the patient, such and such amount of metformin. The patient's blood sugar is this, and they're refusing to eat. Should you or should you not give the medication? And it throws people off because it's a diabetic medication. But really, we can give it regardless because it has such a low risk of hypoglycemia. As opposed to these sulfa drugs and these glitinides, because they actually do increase the insulin and cause an increased risk for hypoglycemia. Again, this one is lower because it's just like in and out. But we still want to make sure the patient's going to eat within that 30-minute window. Okay, so these are DDP4 inhibitors. We talked about GLP-1 and GIP, the incretin hormones, in the last video. And what these drugs do, and these are fairly popular, sitagliptin and linagliptin, or Januvia and Tradjenta, you will see those around, is that they decrease the work of this DDP4. DDP4 is responsible for inactivating, or it works against GLP-1 and GIP, those incretin hormones we talked about. I actually think that I made a little thing here for it. Yeah, so this is from the other video, but if you remember, these incretin hormones are these two types of hormones that are released from the intestines, the small intestines. One of them is released from L cells, the other is K cells. I wouldn't bother memorizing that. But their job is to stimulate the release of insulin and the decrease of glucagon in the pancreas. So when we eat, we're in a fed state, we feel full, GIP and GLP are released, and they trigger the pancreas, the beta cell, for example, to release insulin, and the alpha cell to decrease the release of glucagon. So these kind of GLP, GIP are kind of kicking off the party a little bit, right? And so if we have something that, because it's the human body, we always have something that's working against whatever we're talking about. So in this case, we have this DDP4 that works against incretin hormones and slows this whole process down. And so if we can inhibit this a little bit, maybe we can have that process working quicker. We can have more insulin being released. And that's kind of the theory behind this Januvia and Tradjenta, or the gliptins. They inhibit that DDP4, they increase the GLP and GIP and then which are, again, they're called incretin hormones because they release or trigger the release of insulin. And then when you have insulin being released, you have all of these things, same as what we've talked about before. So this one has a bit of a slower onset, and so it's good for keeping your fasting and postprandial kind of glucose concentrations within normal limits. Adverse effects. One of the side effects of GLP and GIP is that they cause satiety. We talked about this in our metabolic video. So it's going to slow gastric emptying, makes you feel full, so you may not eat as much and you may experience some weight loss. Again, the risk of hypoglycemia is fairly low with this one. Still something, you have to be aware that you are giving somebody insulin or causing a higher release of insulin, but it's because it's kind of This one's kind of like a slow release and a long day kind of release. And so it's not as much of a risk for hypoglycemia, not as much as the sulfas. Again, we're contradicted in DKA, caution for heart failure, renal impairment. If you're giving it with a sulfa or an insulin, you might want to decrease the dose. They work synergistically, so you just need to be a little bit careful, but that's common sense. I don't think you'll miss a question about that. And actually, while we're talking about that, I did want to mention that many of these medications are taken in combination. And what that means is you will likely start out with Metformin, for example, but you will end up oftentimes adding or subtracting other medications.